Imagine going through a major life-altering surgery, like a hysterectomy. You think the worst of your health battles are finally behind you, right?
Right, you expect those pelvic floor issues to just be completely resolved.
Exactly. You think you're in the clear, only to find out, maybe a few years later, that the internal scaffolding of your pelvis has essentially collapsed.
Yeah, and your organs are, well, they're literally descending.
It's terrifying. You're faced with this huge choice about how to fix it.
It's a devastating reality for a significant number of patients. I mean, the uterus isn't just an organ, it's a structural keystone in the arch of the
But
pelvis.
when you remove it, you're inherently disrupting the biomechanics of that whole area.
Absolutely. And when that surrounding structure fails later on, the question of how to effectively repair it becomes incredibly complicated.
And that complication, that's really the core of our deep dive today. If you're dealing with complications like post-surgery prolapse or severe tissue laxity, what is the actual path forward?
Do you undergo a secondary major abdominal surgery?
Right. Or can you turn to these new, heavily marketed energy-based devices? You know, the radiofrequency wands or vaginal lasers that promise to fix the issue in a med spa chair.
Without ever going under the knife.
Exactly. The appeal of a non-surgical fix is totally undeniable, which is, why the marketing for these devices has just absolutely exploded.
Oh, it's everywhere. But to figure out if that marketing actually aligns with medical reality, we have to look past the shiny brochures and dig into the actual clinical data.
And we've got a really dense stack of sources today to help us do that.
We do. We are pulling from the latest surgical guidelines and randomized clinical trials published by major international health authorities.
Right. We're looking at data from the Royal College of Obstetricians and Gynecologists, the National Institute for Health and Care Excellence, the American Urogynecologic Society.
As well as the Brazilian Federation of Gynecology and Obstetrics, or FEBRASCO.
It's a lot. But our mission today is to decode all that medical jargon. We want to separate the structural failures from the tissue issues and give you a really clear map of what works.
What doesn't work?
Yeah, and what the clinical data actually proves about surgery versus radiofrequency. So we basically have to become medical detectives here.
I like that framing.
Yeah.
And to understand what the data is telling us, we first have to understand the specific crime scene we're looking at.
Right. What is actually happening in the body after a hysterectomy?
Well, the clinical literature focuses heavily on something called post-hysterectomy vaginal vault prolapse, or PHVP.
And they define this very specifically in the sources, right? It's not just a general feeling of heaviness down there.
No, not at all. It's a highly precise, measurable event. The sources define PHVP as the descent of the vaginal cuff scar to a point that is 2 centimeters less than the total vaginal length above the hymen.
Wow, okay, so it's a very objective physical drop.
Exactly. Think about the anatomy for a second. The uterus is gone. The top of the vagina, which we call the vault, has essentially lost its primary suspension cables.
The uterosacral ligaments.
Right. And without that upward tension holding it in place, the vault begins to literally invert. It falls inward and downward toward the vaginal opening.
Okay, let's unpack this with an analogy just to ground it for everyone listening. Think of your pelvic floor like a house.
Okay, I'm with you.
So a prolapse, like PHVP, is when the concrete foundation cracks and the load-bearing walls just completely collapse. The physical scaffolding has given way.
That's a great way to look at it,
Right.
because we have to contrast that with what the literature calls vaginal laxity or genitourinary syndrome of menopause or
Yeah.
GSM.
Right, so in our house analogy, laxity is when the drywall gets soft and the wallpaper starts peeling.
Exactly. It is a localized tissue problem. It is not a massive structural support problem. And the clinical world relies heavily on that exact distinction.
Because they're completely different problems.
What's fascinating here is how doctors actually measure this. They use a standardized physical exam called the Pelvic Organ Prolapse Quantification System.
The POPQ, right?
The POPQ, yes. They use it to grade the severity of that structural collapse. They map out exactly where the tissues sit.
And what does the POPQ reveal?
It reveals that laxity and structural descent require entirely different interventions. If a patient feels a physical bulge protruding, they are dealing with a structural load-bearing failure.
The foundation is cracked.
Right. But if they're just feeling a lack of sensation or looseness, that points to a tissue quality issue, the drywall.
Okay, so that means the treatment absolutely has to match the specific mechanics of the failure.
Precisely.
So focusing on that load-bearing failure first, if the vault is actually falling,
Yeah.
how do surgeons go in and prop it back up?
When a patient requires anatomical reconstruction, the clinical data really points to two primary surgical approaches.
Okay, what's the first one?
The first is sacrospinous fixation, or SSF. This is usually performed vaginally. The surgeon physically sutures the top of the descending vagina to a very sturdy ligament located on one side of the lower pelvis.
Got it. And the success rates for the vault itself, reading through the trials, they're actually quite high, right?
They are. The clinical trials show an 89.3% success rate for keeping the top of the vault suspended.
That sounds amazing.
Yeah.
And this is a massive but, there is a catch.
A very big catch.
SSF comes with a nearly 48% recurrence rate for what's called a cystocele,
Yes, that is a prolapse of the anterior vaginal wall.
essentially the bladder dropping. So nearly half of these patients end up with a secondary prolapse. Why does fixing one area cause another to fail so frequently?
It comes down to the biomechanical shift caused by the surgery itself. With SSF, you are taking the top of the vagina and pulling it aggressively backward and to one side to anchor it to that ligament.
So you're creating this really strong but highly unnatural backward tension.
Exactly. The front wall of the vagina, which sits right under the bladder, isn't directly supported by that new backward stitch.
Ah, I see.
So over time, that abnormal tension and altered pelvic angle cause the front wall to stretch, weaken, and eventually drop. And it takes the bladder right down with it.
Wow. So what does this all mean for someone choosing a procedure? Are we just, trading one structural problem for another?
In many cases with SSF, unfortunately, yes. You fix the falling vault, but trade it for a falling bladder a few years down the line.
That is just a brutal reality for a patient to face.
It is. Which completely explains why the clinical guidelines, including the ones from the Royal College of Obstetricians and Gynecologists, lean so heavily toward the alternative approach.
Laparoscopic sacrocolpopesy, or LSC.
Right. In an LSC procedure, the surgeon goes in through the abdomen using small incisions.
So not vaginally?
No, laparoscopically.
Yeah.
And instead of pulling the vagina off to one side, they use a piece of synthetic mesh to act as a new centralized suspension bridge.
Okay, so they're rebuilding the scaffolding.
Exactly. They attach the vaginal vault directly to a ligament on the sacrum of the lower spine. This mimics the original natural anatomy of the pelvis far more accurately. It distributes the tension evenly.
But introducing the word mesh immediately raises red flags for a lot of patients.
Oh, absolutely. And understandably so.
Given the massive lawsuits and the horror stories surrounding vaginal mesh in recent years, people are terrified of it. But the clinical guidelines tackle this controversy head-on, don't they?
They do. They compare the laparoscopic abdominal approach, the LSC, to transvaginal mesh, or TDM, where the mesh is inserted directly through the vagina.
And when you look at the patients 2 years out from these surgeries, the difference is just staggering.
It really is night and day.
The highlighted randomized clinical trial shows the laparoscopic approach resulted in a 2% mesh erosion rate. But the transvaginal approach, that had a 13% erosion rate.
And just to clarify for everyone, mesh erosion is when the synthetic material essentially rubs through the surrounding human tissue, exposing the mesh.
Which sounds horrific.
It is agonizingly painful. It causes chronic bleeding, and it requires really complex surgeries to go back in and remove the embedded material.
So wait, both of these procedures use synthetic mesh to prop up the organs. Why does the route the surgeon takes to insert it change the failure rate so drastically?
It is entirely about tissue integrity and the biological environment of the incision.
Okay, how so?
When a surgeon goes in laparoscopically through the abdomen, the vaginal wall itself remains completely intact. The mesh is placed on the outside of the vagina against a smooth, unbroken surface.
Right.
But with transvaginal mesh, the surgeon has to slice directly through the vaginal wall.
Meaning you've just created a surgical weak point right over the exact spot where you're implanting this stiff foreign body.
Exactly. Plus, you are introducing that mesh through a corridor of the vagina that naturally harbors bacteria.
So you're dramatically increasing the risk of subclinical infection and poor tissue healing right off the bat.
That is the exact mechanism of failure. The tissue over the transvaginal mesh is already compromised by the incision, and then it's immediately tasked with bearing the heavy structural load of the pelvic organs.
So over time, that weakened, stitched tissue simply gives way, and the mesh erodes straight through.
Precisely. This is why the reoperation rate in the data was 5% for the laparoscopic group, but a massive 22% for the transvaginal group.
22%. That's huge.
It is. The abdominal route protects the structural integrity of the vaginal wall.
But I mean, even with this safer laparoscopic approach, surgery is still a major traumatic event for the body.
Oh, without a doubt.
You're looking at general anesthesia, significant operating times, hospital stays, and, the permanent integration of synthetic mesh. It's a heavy structural lift.
Which perfectly explains the massive consumer demand for an alternative. Patients are understandably terrified of the surgical risks and the downtime.
Right. Nobody wants to go through that if they don't have to.
They want a solution that doesn't involve scalpels or synthetic implants.
And that demand has birthed this booming industry of energy-based devices, radiofrequency, and lasers.
Yes, the EBDs.
You see these machines in every high-end medical spa, every gynecologist's office now, promising tissue tightening and rejuvenation in a, 30-minute outpatient appointment.
It sounds like magic.
It does. Let's look at radiofrequency specifically because the mechanism here is actually fascinating. It's not just blowing hot air on the tissue.
No, the cellular biology behind radiofrequency is quite sophisticated. The device emits an electromagnetic current that forces the intracellular ions within your tissue to oscillate rapidly.
So they're vibrating incredibly fast.
Exactly, and that intense microscopic movement generates heat from the inside out. The devices are calibrated to target a very specific temperature window within the tissue between 40 degrees and 45 degrees Celsius.
All right, let's pause on that temperature for a second. Because heating human tissue to 45 degrees Celsius sounds a bit like microwaving leftovers.
I know, it sounds alarming.
How do we know it's actually safe? What is happening at a cellular level that makes this beneficial rather than destructive?
Well, that 40 to 45 degree window is the critical threshold in cellular biology. If you heat tissue past 45 degrees, you cause thermal ablation.
Meaning you're literally burning and destroying the cells.
Right. But hovering right in that 40 to 45 pocket triggers something called biomodulation. The heat stresses the tissue just enough to activate heat shock proteins.
Okay, so it's a controlled microscopic injury.
Exactly. You are essentially tricking the body into thinking it has been damaged, so it mounts a massive localized healing response.
The body rushes blood flow, hydration, and fibroblasts to the heated area.
Yes, and fibroblasts are the cellular workhorses responsible for building new collagen and elastin fibers.
Wow.
So over the course of a few weeks, that heat-stressed tissue begins to aggressively remodel itself. It becomes thicker, more hydrated, and far more elastic.
And the clinical studies backing up this mechanism, reading through them, they're genuinely impressive.
They really are.
There's data on a device called jet plasma, which utilizes a specific type of radiofrequency called electroporation.
Right, where it sends micropulses of energy.
Yeah, and it actually creates temporary pores in the cell membranes, allowing for massive cellular hydration. The study showed a 100% average increase in vaginal mucosa thickness.
It literally doubled the physical thickness of the vaginal lining. For a non-surgical, painless procedure, those are remarkable outcomes.
Truly.
Other trials, like the VIV-EVE trial, show that for conditions like the genitourinary syndrome of menopause, which involves severe dryness and tissue fragility, radiofrequency achieves results that are comparable to prescription estrogen therapy.
And far superior to over-the-counter moisturizers.
Exactly. It significantly improves sexual function and reduces the physical sensation of laxity.
So if we go back to our house analogy for a moment, the radiofrequency is an incredibly effective tool for repairing the drywall.
Yes.
It restores the surface lining beautifully. But what happens long-term? Because we are repeatedly inducing localized heat trauma to stimulate collagen.
And that is the exact blind spot that has the major medical societies issuing heavy warnings.
Right. When you read the official guidelines from the American Urogynecologic Society, or AUGS, they are explicit. Energy-based devices are still not considered the gold standard for treating any pelvic floor condition.
Because we only have data on the immediate aftermath. The clinical trials show us what the tissue looks like at 6 months or maybe a year.
But we have no robust, randomized data on what happens to that vaginal tissue 5 or 10 years after it's been repeatedly heated to 45 degrees.
None. We don't know the long-term cellular consequences of foisting that biomodulation over and over again.
And that lack of long-term safety data becomes incredibly important when we pit these two treatments head-to-head to answer the central focus of this deep dive.
Right, let's bring it all together.
Okay, so if you've had major pelvic surgery, like a hysterectomy, and you're dealing with a severe structural complication like vault prolapse, is a secondary surgery better, or can you use radiofrequency to fix it?
The clinical consensus from the sources is absolute. Laser and radio frequency cannot correct moderate to severe prolapse.
Really?
They are biologically incapable of fixing an anatomical failure.
Wait, hold on. Let's look at the mechanisms we just discussed. If radiofrequency is literally doubling the thickness of the vaginal lining,
Right.
if it's triggering this massive rush of collagen and tightening the entire area, why wouldn't that just shrink a prolapse back into place?
I see what you're saying.
If all the tissue in the vaginal canal is tightening up and becoming denser, shouldn't it pull the descending organs up with it?
It sounds intuitive, but it fundamentally misjudges the anatomy of a prolapse. If we connect this to the bigger picture, we have to separate the mucosal lining the surface tissue from the deep pelvic fascia and ligaments.
Yeah, explain that.
Radiofrequency only penetrates a few millimeters deep. It is solely remodeling the surface lining. A post-hysterectomy prolapse is a massive failure of the deep, load-bearing ligaments holding the top of the vaginal vault to the spine.
Oh, I get it. So the drywall cannot support the root.
Exactly.
You can have the strongest, thickest drywall in the world thanks to the radiofrequency. But if the load-bearing beams have snapped, the walls are still coming down.
Spot on. And the people designing the clinical trials for these devices, they know this.
They do.
Oh, yeah. If you dig into the fine print of the exclusion criteria for these radiofrequency trials, they specifically prohibit certain patients from participating.
Wow. Who do they exclude?
They exclude patients who have had previous reconstructive vaginal surgery. They exclude anyone with a history of pelvic radiation. They exclude anyone with prior mesh placement.
So basically anyone who's had major pelvic trauma.
Yes. And they outright exclude anyone with a stage 2 or greater prolapse.
So they don't even test these devices on post-surgery prolapse patients because they know the technology wasn't designed to fix structural failures.
Correct. But the problem is, patients are still seeking out these treatments off-label, hoping to avoid another surgery.
Because they're terrified of surgery, like we said earlier. But there's a chilling, highly specific case study in the literature that shows exactly what happens when you ignore those exclusion criteria.
It is a profound cautionary tale.
Tell us about it.
The case details a 55-year-old woman who had a history of a hysterectomy and also had previous surgical mesh slings placed. She sought out 3 consecutive vaginal laser treatments, likely hoping to address discomfort or laxity without another surgery.
And the clinical notes describe the aftermath as disastrous.
Completely disastrous. She developed severe levator antispasms.
For anyone who hasn't experienced that, a levator antispasm isn't just a cramp, right?
No, it is a severe, chronic, agonizing clenching of the deep pelvic floor muscles. It makes sitting down feel like you are resting on a knife. It makes intercourse completely impossible.
So what actually happened inside her body?
The heat from the laser interacted catastrophically with her previous surgical sites and the embedded mesh. Instead of generating fresh, elastic collagen, the laser caused progressive, severe scarring throughout her pelvic floor.
That's horrifying. The sources say her treatment plan required nightly off-label use of intravaginal Valium, a heavy sedative, just to paralyze the muscles enough to stop the agonizing spasms.
Yes, along with intensive physical therapy, using dilators just to regain basic everyday function.
Which brings up a critical biological mechanism that the Brazilian Federation of Gynecology and Obstetrics Brasco specifically warns about in their clinical guidelines, which is fibrosis.
Right, fibrosis, it's the dark side of tissue remodeling.
It's the formation of dense, rigid, inflexible scar tissue.
Exactly. When you repeatedly heat healthy tissue, you get elastic collagen. But when you repeatedly heat tissue that has already been severely traumatized by major surgery or tissue that has a synthetic mesh embedded in it, you disrupt the normal healing process.
So you aren't rejuvenating the tissue anymore.
No, you are essentially cooking it into a stiff, painful brick of scar tissue. The heat triggers a hyperinflammatory response in the already damaged area.
Which means using these energy devices on a severe post-hysterectomy patient isn't just ineffective at fixing the prolapse. It is actively physically dangerous.
It is. The clinical data forces a very clear conclusion here. For post-major pelvic surgery, structural issues where the vault is actually falling or the organs are descending, surgery remains the vastly superior and, frankly, the only biologically viable choice.
You have to physically go in and reconstruct the load-bearing anatomy.
Exactly. There's no laser in the world that can reconnect a severed ligament.
The answer to the big question entirely relies on accurate diagnosis.
Yeah.
You have to separate the symptoms of laxity from the mechanics of an actual structural prolapse.
Right. If the issue is anatomical repair, surgery is the necessary heavy lifter. Laparoscopic sacrocolpopexy, despite the inherent surgical risks and the use of mesh, provides the objective long-term cure because it mechanically rebuilds the scaffolding.
It rebuilds the foundation.
Yes. Conversely, if your underlying structural scaffolding is perfectly sound and your diagnosis is purely a tissue quality issue, like severe dryness, mucosal thinning, or mild stress incontinence, then radiofrequency and lasers are highly innovative, effective tools.
They can remodel the surface collagen and significantly improve your daily quality of life without exposing you to the risks of general anesthesia or synthetic implants.
Exactly. Diagnosis dictates the tool.
You use the radiofrequency to repair the drywall, and you use the surgery to rebuild the foundation.
It sounds incredibly straightforward when laid out like that, but the current medical landscape makes it very difficult for patients to navigate.
Which leaves us with a final lingering question to ponder based on everything we've read in these clinical guidelines today. We are watching these energy-based devices become massively commercialized, right? They're heavily marketed on social media as quick, painless, cosmetic tightening fixes for any pelvic floor discomfort.
It's a huge trend.
So as this trend accelerates, are we risking a future where women undergo repetitive, expensive heat treatments for a perceived laxity issue, completely ignoring the underlying biomechanical health of their pelvic floor until a severe, catastrophic prolapse inevitably occurs?
It's a real fear. When the marketing outpaces the diagnostic medicine, the underlying foundation is almost always what suffers.
Something to keep heavily in mind the next time you see an ad promising a quick, painless fix for a complex bodily system. Thank you so much for joining us on this deep dive into pelvic floor restoration. Remember, your biology is complex, the underlying data always matters, and you should always keep questioning the world around you.